Good evening to all. It's great to have you all back for the much awaited masterclass by Dr. Abha Majumdar, ma'am. Today, ma'am is going to talk on a clinical dilemma we frequently encounter in our practice, the dilemma of deciding between surgery or ART in infertile women with endometriosis. So, over to you, ma'am.
Thank you, Bhavani, for starting the ball rolling. And I would be very happy if, out of all those who have joined in today, could bring in special cases. And I would also want to discuss one case only which came to me today. And the same dilemma was there, that what should we do for her? So let us see what literature says and what evidence we have. Now, which should be the first approach, IVF or surgery with a girl who comes with ultrasound diagnosis of endometriosis? And once on ultrasound, when you see endometriosis, then it is already stage 3 or maybe stage 4 and could be quite severe, where only very expert laparoscopist could really justify the clearance of the endometriosis. So we need two types of information. One is a general set of information and a personalized set. And we should be no one to say, you should have this. You can only give your opinion, tell all the pros and cons of both the procedure, and let the patient take her choice as first. So, general set of information which the patient should know, that after surgery also there is 25% live birth rate after surgery in the next 6 months or maybe even 9 months. In the past, even in IVF, 25% live birth was there. Now it has gone up to 35-40%. But it happens faster. Cost is center dependent in both things. The risk of hemorrhage, organ injury, infection, and anesthesia complications are much higher with surgery vis-a-vis anything in IVF. Possibly the risk of hemorrhage, organ injury, infection is very, very low. And endometrioma infection may happen if we try to do IVF without removing the endometrioma and we puncture the endometrioma. And another very big disadvantage of surgery is damage to ovarian reserve, which is so common. Even in expert hands, the ovarian reserve may lessen by 40%. Whereas on IVF, on the other hand, risk of OHSS and multiple pregnancy was quite common. But then this has also become something of the past with the development of antagonist protocol, agonist trigger, and segmentation of the cycle since 2011. OHSS also happens very rarely, and multiple pregnancy with single embryo transfer. So these are the general set of information which should be given to the patient about the live birth, cost, the risk, and ovarian reserve complications. On the other hand, there is a personalized information which each patient requires on her own merit. What favors IVF? If she's already had previous surgery for endometriosis. Number two, bilaterality, because if we try to operate on both the ovaries, there would be severe impairment of ovarian reserve after surgery on both sides. And these are cysts of significant sizes. We don't even consider removing a cyst of 3 centimeters in a woman who's 40 and who has ovarian reserve, which is borderline. Then the older the woman is and her ovarian reserve is low, say, like I told you, of 40, I wouldn't want to do a surgery if she has cysts which are not really large. And if there is any associated factor like male factor, tubal block, we naturally think of IVF. When do I think of surgery? When I see a young woman and I feel that her cyst can easily be removed, she has a very good ovarian reserve, and they are ready to wait. Apart from that, what favors surgery is the ultrasound appearance of a large cyst with a doubtful diagnosis, where you think, oh, it's got some solid components within. They could be hemolyths, but otherwise you may not. And the tumor markers are indecisive in all these cases. So if you see larger cyst or the cysts are growing very fast, there's doubtful diagnosis, and you want to rule out malignancy, 100% one should go for surgery. If there is so much pain, which is not relieved by medical treatment, then also surgery becomes very important, because the person does not want to get pregnant till her pain is relieved. And another one is when you see the antral follicles are away from the vaginal wall. There, what will happen? Every time you will want to take out, you will want to aspirate a follicle, you would have to go through the cyst into the follicle. And there, the chances of infecting the cyst becomes very high. So these are absolutely personalized information, which is patient-centric. Specific risk of surgery, again, I reiterate the whole thing: negative impact on ovarian reserve and responsiveness to controlled ovarian stimulation, major complications in around 10% of cases, especially when cyst surgery is associated with removal of deep infiltrating endometriotic lesions. Then another one is recurrences after cystectomy. You do a cystectomy, tell the patient try to get pregnant in the next 4, 5, 6 months. And then after that, when the patient comes back to you, you find that endometriosis is again creeping up. I'm not even talking about incomplete endometriosis surgery, where the endometriosis is seen after 1 month of surgery also. These are incomplete surgeries, and they lead to unnecessary and repetitive surgeries. Then I also want to bring this to everyone's notice that a lot of GnRH agonist is given after surgery, saying that whatever deep little endometriosis is left, that will get suppressed. But it is absolutely inappropriate if you downstage the disease by surgery, because GnRH agonist becomes a contraceptive. And the first 3 months, where the patient is most likely to get pregnant, only if she's ovulating. So if she's not ovulating, her chances of pregnancy goes. And whatever suppression of remaining endometriotic lesions you've done, you have left the patient to redevelop adhesions. And these adhesions make this patient who has not ovulated all these days more difficult to conceive after 3 months when she leaves her GnRH agonist. What are the specific risk of IVF? Well, as I told you, if we go through the endometriotic cyst multiple times, we can have a tubovarian abscess. People thought that there was risk of disease progression, but now it has been proven that it does not exacerbate the progression or recurrences of endometriosis. Then again, we go back to the older times when multiple pregnancies were generated via ART, whereas spontaneous conception are associated with, spontaneous conceptions are more normal, and ART pregnancies were associated with higher risk of complications and adverse outcomes. But multiple pregnancies now do not happen so commonly in our country. Still, there is a tendency towards two embryo transfer, but countries which have shifted to a single embryo transfer, and our center, which has shifted to a single embryo transfer, since 2015, we are shifting, and from 2018, we've shifted completely to single embryo transfer. We do not see multiple pregnancies in these cases. And we all know, when we do an analysis of naturally conceived singletons, naturally conceived multiples, there is ART is associated with slightly higher adverse obstetric and perinatal complications. Having said that, we have to remember that outcomes with ART are not affected by endometriosis phenotype, which means she could have superficial peritoneal endometriosis, which you only see on laparoscopy, or she could have ovarian endometrioma with adhesions, or she could be having deep infiltrating endometriosis. If the patient goes in for IVF, the inflammatory effect is almost the same, and hence ART outcomes are also the same. Now, I wanted to bring to your notice that in the past, we used to feel that oocyte quality is hampered in cases of endometriosis because of the inflammation which is there with this disease all around the pelvis, which releases a lot of reactive oxygen species and lowers the quality of oocyte. But then this is a huge meta-analysis which was published in Human Reproduction 2022, where they found no significant difference in the live birth rate in women with endometriosis undergoing donor oocyte recipient fresh frozen embryo transfer cycles compared to women undergoing self IVF fresh frozen embryo transfer cycles. So all these women had endometriosis, whether they used fresh, they used their own eggs, or they used donor eggs. In both ways, the live birth rate was similar in both the groups. This study finding suggests that there may be a minimal or no effect of oocyte quality on IVF outcomes in women with endometriosis. So things are changing with time. In the past, we knew very little about the ART procedures. Our pregnancy rates were lower, clinical pregnancy rates were lower. Now our clinical pregnancy rates are going up to over 50%, live birth rates to around 40%, and things are changing. So I just want to speak about what happens when there is an endometrioma and how it affects the ovarian reserve. Now, endometrioma may on its own inflict some damage on ovarian reserve, especially in cases of bilateral endometrioma, because they go on sort of enlarging, and the ones which are through invagination take away the cortex along with it, and all those follicles are got they get lost in this endometrioma, which were there on the cortical surface. So there is a loss of ovarian reserve. And post-surgical damage is the main damage. But if we do surgery, the damage is so much because we peel off the cyst wall, and that leads to, and because these cysts are very densely adherent to the surrounding tissue, a lot of normal ovarian tissue is stuck to the cyst wall when we remove it. So AMH may fall by 40%. Operated ovary shows lower AFC, lower oocytes collected compared to the contralateral non-operated one. So what are the key drivers of success? Experience of the surgeon is one of the key driver of the success. Very efficient surgeon, and who can peel off the cyst, who's very dexterous in removing this and uses less cautery, maybe uses pitocin fluid or otherwise to separate the cyst wall, and doesn't cauterize the normal ovarian tissue. However good the surgeon may be, whatever associated inflammation is there and compromised vascularization happens on account of inflammation and surgical procedure, as well as the use of cautery, laser, whatever you use, that is unpreventable. Post-surgical complete ovarian failure happens in 2% of patients, even in expert hands. And then we have to also remember the cost of surgery is quite a bit when it happens with extensive endometriosis. So surgery prior to IVF, when you decide for surgery prior to IVF, depends on surgeon's skill, cost, possible surgical complications, impact on ovarian reserve, and the chance of incomplete surgery and recurrence, and it delays pregnancy or ART both. When we say no surgery prior to IVF, then what are the negative things? Progression of the disease will happen till ART is undertaken, increase or till the patient becomes pregnant, increase inflammatory reaction, oxidative stress. Sometimes oocyte retrieval becomes difficult, but that also happens post-surgery when the ovary gets stuck behind the uterus. Risk of cycle cancellation, follicular fluid contamination, endometrioma infection, and there could be undiagnosed occult malignancy if we've gone in for IVF in a cyst where we did not think that there could be malignancy, and risk of rupture with subsequent chemical peritonitis. I wouldn't say risk of rupture, there's more risk of spillage of the endometriotic fluid and hence chemical peritonitis. So both the procedures, if we do surgery prior to IVF, then there is risk, out of which I feel the impact on ovarian reserve and the risk of premature ovarian failure is the most prominent to a patient who wants to have a baby. Whereas if we do not operate, then we know that we can lead to endometrioma infection if we are going through the endometrioma, and undiagnosed occult malignancy may be there, which is rare but can happen. So in the past, any ovarian lesion was observed on ultrasound before ART. Gold standard was to remove it in an attempt to clean the ovary and get a better outcome afterwards, regardless of the patient's symptoms. Whereas if you see a large retrospective study 20 years ago, this is by Garcia Velasco, in 2004. Removing endometrioma before IVF did not improve cycle outcome. And a recent meta-analysis just 3 years ago, 4 years ago, said women with endometriosis related infertility going through ART have similar cycle outcomes with or without prior surgery. So, like we used to think that removing endometrioma is very important. Right now, leave the endometrioma there. If you can take out the follicles, and they are towards your needle, the best is to that. I got a patient very recently who came to show me the reports today, and a large surgery was done for her in a very reputed place, bilateral endometriosis. And I think it was a good surgery, but then she comes back after 6 months with a huge collection of 300 cc um, in the pelvis. So it was such that they said one ovary cannot be seen and the other ovary has this cyst. So I did her ultrasound, and very nicely we could see that this was a whole big encysted collection of maybe endometriotic fluid or whatever fluid is there. And this was possibly because of the adhesions created during the surgery. But both the ovaries had stuck to the posterior wall of the uterus, and both had about 5, 6 antral follicles. So I reassured her that I'll do your IVF first, take out all these, aspirate all the follicles, see how many eggs. She's a young 31-year-old woman. And once we made embryos for you, 2, 3, or 4 blastocysts, if we aspirate this cyst and it's just fluid, simple fluid, we leave you alone. Otherwise, we might go in with a laparoscope to remove all this encysted fluid. So a lot of times the diagnosis becomes difficult. I had told her, I had told my ultrasonologist that I want to see whether the antral follicles are distal to the cyst or proximal. And what I found that it was a separate collection of the whole fluid, and both ovaries were on the sides and both were stuck to the posterior wall of the uterus where I could go directly very easily. So let us see what ESHRE 2022 guideline development group says. One is when you look at stage 1 and 2 endometriosis. And when do you diagnose this? Only on laparoscopy. You can suspect it in a patient with stuck ovaries or with a lot of dysmenorrhea or pain, but you can confirm it only on laparoscopy, and clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in women with revised ASRM stage 1 and 2 endometriosis, as the potential benefits are unclear and this recommendation is strong. Then clinicians are not recommended to perform surgery for ovarian endometrioma, which means stage 3 and 4, prior to ART to improve live birth rates, as the current evidence shows no benefit and surgery is likely to have a negative impact on ovarian reserve. This is also strongly recommended. Then surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or accessibility of follicles. This is a general practice point, which looks a good practice point, which is okay. And last, again, strongly recommended is the decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient's preference, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. I just told you the phenotype does not change the live birth rate, and therefore going for a surgery should be by a very expert surgeon who can handle gut injury, vascular injury, if she has so much pain that one needs to remove the deep endometriosis. Now, previous versions of ESHRE guideline development group still considered the size of endometriotic cyst as an indication for surgery, regardless of symptoms or any other issue. But now we are very clear there is no size which says surgery is a must. It is only the doubt of malignancy which is there with uh, enlarging endometriotic cyst, rapidly enlarging endometriotic cyst, where we feel that surgery is a must, or the pain is so much that the patient is unable to have a normal life. And last, I told you if the follicles are away. So, and if we feel that, yes, you have to do a surgery because you suspect malignancy and you cannot leave her just like that, then we need to offer them oocyte cryopreservation before surgery. And here the random stimulation protocol comes into play, because if the patient has come to you on day 8 or 9 or 10 of her cycle, you can offer her quickly ovarian stimulation, taking an ovarian stimulation with very low estrogen levels. For that, we give a letrozole with gonadotropin protocol, and then take out all the oocytes. And then immediately after that, we can take her for a surgery. So patients may be overwhelmed by the burden of contrasting information. It depends on if a surgeon is like decision should be based on transparent and complete information. The question cannot be reduced to simplistic approach to try surgery first. We cannot just say try surgery first, or on the other hand, we can't even say try IVF first. It has to be absolutely realistically understood. Physicians may be tempted to guide decision based on their own values and competencies. Now, a endoscopic surgeon who's very good will always say that, oh, get this removed, your pelvis will clear out, everything will be, and people know that this is a damn good surgeon, and hence ovarian reserve may not be affected. But even with damn good surgeons, 40% reduction will happen of the ovarian reserve, and 2% will go into absolute ovarian senescence. So shortening time to pregnancy is preferred for most couples. Now, these days, a couple walks into the clinic who was married 8 years and is trying pregnancy for just 6 months, and in that attempt finds out that she has endometriosis. Even if IVF and surgery had the same success rates, this desire may favor IVF because they have their plans sketched out. They don't want to waste time on surgery and then try for 1 year. They like to have their plans set in, their goals set in. They want to have a pregnancy and be free by the end of 1 year so that they can proceed with their plans. So current trend to postpone pregnancy is also favoring this. Like I just told you, married for 8 years, but then want to have a pregnancy when they start trying for 6 months or maybe 1 year. And they generally come seeking for it in late 30s, 37, 38, 39, when natural fertility is on a decline already. So again, IVF is favored. And this statement came up from the ESHRE Capri workshop group, a prognosis-based approach to infertility, understanding the role of time. So time becomes a very important factor in today's Z-Gen, where they don't want to wait once they've decided now we want to get pregnant, and then something stops them from getting pregnant, and they are sitting in a clinic after even 3 months of trying to go for IVF. So the dogma that endometrioma surgery is the systematic first-line therapeutic option warrants being revised. Surgery is not necessary for all cases which present with endometriomas. Today, as a rule of thumb, surgery for endometrioma before IVF should not be performed unless the patient has pain that interferes with her daily life, or on ultrasound, one detects either rapid growth of cyst or sonographic features of malignancy. Try IVF first should not be a physician's decision, but in most cases, it will be the decision of a properly informed patient. So you have to tell the pros and cons of both, and you have to assure that yes, IVF can be done in your case. If we can take out enough eggs and make embryos, you should be quite okay with surgery in case you want to have the surgery later. But then pregnancy is the best cure for endometriosis. 9 months of amenorrhea and then lactational amenorrhea all takes care of the endometriosis if it is not too severe. Having said that, I would want to take a few minutes on impact of adenomyosis on IVF outcome. Now, you have taken out the eggs, you have made good embryos, you've made blastocysts, you want to transfer them in the uterus. And we all understand endometriosis and adenomyosis are brothers and sisters. I call endometriosis the sister and adenomyosis the brother. The pathology is the same. In endometriosis, we feel retrograde menstruation with implantation on cells which have a potential to implant these cells and then get VEGF exposure and vascularization. And these implants start menstruating with exposure to estrogen and withdrawal. Similarly, inside the uterus also, as time passes and as a girl grows, the basilar layer of the endometrium gets broken at places, and this blood, due to sometimes the pressure in the uterus is higher, while the blood is being extruded out of the cervix into the vagina, this little endometrial implants with some blood drops pass into the muscle fibers of the uterus. And then they also act the same way. They also get sensitive to estrogen and they also bleed. So every menstruation, the pain is immense. These adenomyomas become larger and larger, and sometimes they are so large that they make cyst. However, we feel that does this adenomyoma impact IVF outcomes? We were just now spoken about endometriosis, and I've told you that whatever reactive oxygen species and inflammatory process is there, it has very little impact on egg quality and hence embryos. Now, adenomyomas, there are nth number of studies. Some studies report no adverse effect, while others show that poorer outcomes of IVF happen, and there is increased incidence of miscarriage in infertile women with adenomyosis. Now, if you see the features of adenomyosis, then if a patient has greater number of ultrasound features of adenomyosis, they may have lower clinical pregnancy rate in IVF ET. And there is a very good classification of Musa classification. I'm sorry, I did not bring it here, where you get to see all the signs of adenomyosis, and the larger the number of um, the larger the number of these signs you find in a uterus, you have a greater chance that you will have a lower pregnancy rate. Then size is also very important. If the uterus becomes large due to adenomyosis, this also is related to poor pregnancy outcomes in women undergoing IVF ET. Now, having said this, size and features of adenomyosis, both of them are equally responsible for lower clinical pregnancy rate and for a greater miscarriage rate. So here I've just brought in two studies, large prospective cohort study of women undergoing 4,002 IVF cycles. 1228 fulfilled the inclusion criteria, concluded that women with and without ultrasound features of adenomyosis had no significant difference in most of their IVF outcomes, including live birth rates. Now, this study, if you read, has very few adenomyotic features. They have not taken size into consideration, but just features. But then another recent study compared the clinical outcomes of 158 adenomyosis patients enrolled for IVF. Uterine volume before frozen embryo transfer was negatively correlated with live birth. And then one of our students also did this study, and she also found that the cutoff value for the ROC curve for the size of the uterus was, say, about 100 cubic centimeters. So if the size, now we need to learn to calculate the uterine size by taking the depth, length, and width of the uterus, and then putting the coefficient of 0.6 into it and finding the volume. But you will find normal uterus volume between 30 to 40 cubic centimeters, sometimes a little lower, a little higher. But then if it becomes 100 centimeters, that means it is 3 times the normal size. And in weeks, if we call, it is 10 weeks, more than 10 weeks of normal size. Even if you do sounding, the cavity is more than 10 centimeters. These uteruses are poor for implantation, and hence it is very common practice and advisable that we control the uterine volume before embarking on FET procedures for any patient. So, on one hand, endometriosis, we are leaving it there. We are taking out eggs and making embryos, and then we deal with endometriosis whichever way we want. With that, if there is adenomyosis and the volume of uterus is high, and you feel that adenomyomas or volume is not so high, but there are 3, 4 large adenomyomas with all type of signs, and it is best to treat these patients to reduce the uterine size, and possibly we would get better outcomes. So This is Best Practice and Research Clinical Obstetrics and Gynecology 2018. And here, if you see what do they say, is if there could be slight disease, few symptoms like just dysmenorrhea, there could be moderate disease when you see uterus is larger, and severe disease when uterus is really very large. So if there is slight disease, few symptoms, you just go for IVF the way you go, 2-3 cycles, oocyte retrieval, cryopreservation. And if you can see cyst, this is now a very important thing, that hysteroscopic treatment of cyst, if you see adenomyotic cyst just beneath the endometrium, if the ultrasound shows these cysts, it is best to go in hysteroscopically, evacuate these cysts by just burning off or cutting off the upper layer, give them GnRH agonist for 2-3 months, and then transfer the cryopreserved embryo in whichever cycles you want. In 1 or 2 cycles, if it still doesn't work, then you can give GnRH agonist for another 2-3 months and transfer of embryos. Now, if there is moderate or severe disease, the aim is the same. First is oocyte retrieval and cryopreservation. Now, why do we write 1 to 6 cycles? Maybe 1 cycle you may not be able to get so many eggs and so many embryos, because these are generally compromised patients with their ovarian reserve. And then if you see cyst, hysteroscopic treatment of cyst are very important. So if there is adenomyosis, hysteroscopy is important. If on ultrasound you see subendometrial cyst, even if you see subendometrial calcifications, sometimes this blood calcifies and appears like that. So maybe one needs to just cut in these areas and see. Cyst can be seen as a blue color bulge over the endometrium, and just making a small snip on that or using a little fulguration helps. Now, for these large uteruses, GnRH agonist is not given for 2-3 months, but it is given for 2 to 6 months. And then, when your uterus size, you assess the uterus size after 3 months. If you find it is still large, you continue GnRH agonist for another 3 months, and then you transfer your cryopreserved embryos, 1 to 2, whatever you want per cycle, and repeat 2-3 times. Now, here, age also is very important. If there is localized disease and the woman is young, you can think of doing a surgery and removing the adenomyoma. Whether you do it laparoscopy or laparotomy doesn't matter. If the woman is more than 40 years and has diffuse disease, then GnRH agonist for another 3 to 6 months. So there was a lady who came from Australia, and she gave a lecture, and she said, I have even given GnRH agonist for 12 months with a little add back therapy to reduce the size of a uterus before I do transfers, and it does work for them. So we have to freeze embryos in all these cases. We need to make sure that we've seen the uterus is okay for transfer. If it is okay, you do nothing. I do nothing if I see no subendometrial cyst. I don't even do a hysteroscopy, but we should look for these cysts carefully. And after hysteroscopy, one can give GnRH agonist for 2 or 3 months, but it is not mandatory. You can do a transfer after 1 month also. And therefore, to conclude, adenomyosis, surgery or medicine, adenomyosis is only of substantial volume and size could have detrimental effects on IVF outcomes. It might reduce the pregnancy and live birth rates and increase miscarriage rates. So ordinarily, if we take out embryos and adenomyosis, volume of the uterus is okay, patient has no symptoms and she looks all right, we don't give any pre-treatment. In the next cycle, we'll do a frozen embryo transfer. Medical pre-treatment with GnRH agonist for 3 to 6 months before embryo transfer is an effective way to reduce uterine volume and increase the clinical pregnancy rate in the setting of adenomyosis. However, surgery could be considered for localized large adenomyomas. Thank you.
Thank you, ma'am, for explaining this topic with so much clarity. We can now have the questions. So you all can post your questions. We already have some. Dr. Anupama wants to know, before FET, if we see an endometrioma, should it be removed?
Before, no, nothing. Anupma, please do not try to remove endometrioma if you've already made Unless the endometrioma is such which you had thought that you want to remove, it's very huge, it is giving patient problems, then you remove. But you be sure that you have enough embryos that you would be able to give her a pregnancy. You have to be sure on your implantation rates, pregnancy rates, and embryos before you think of removing. If you have, say, two blastocysts, and you feel that she may not get pregnant, then in that case, please do not think of removing her endometrioma. You can collect more oocytes. Okay?
Excuse me, ma'am. Hello.
Hello? Yeah, yeah.
Yeah, this is Dr. Anita. Sorry, I'm interrupting in between because my question is related to this answer.
Mhm.
Um, Previously, when we were studying in the school life, it was saying that in the endometriotic patient, the peritoneal fluid is also not a good environment for the egg or embryo. So, if we are transferring the embryo in the presence of endometrioma, is it not going to affect?
I I think you did not hear the whole talk then. I'm sorry, because I explained that oocyte
No, no,
quality is not affected, embryo quality is
I
not
joined
affected,
I joined
inflammation.
I joined from very beginning, ma'am.
Okay.
I listened about the egg quality, but here she is asking, she has already embryo or frozen embryo. Now she is going to transfer. So before transfer, also it is not advisable to remove the endometrioma.
No, it is not advisable because once the uterus is healthy and doesn't have endometriosis, which is very severe, then you don't need to remove anything. You can just leave it there. But yes, if she has a very large cyst and you feel that this cyst should be removed, then only you remove it. But be sure that you have enough embryos. Okay.
So the cutoff for this endometriotic cyst, how we can say that, like previously it was said that 4 centimeter or 3 centimeter. So now if we are thinking that large mean more than 5 centimeter.
No, nothing is large now. The things
Uh-huh.
have changed. Earlier, we used to think that all endometriotics is larger than 3.5 need to be
Yes.
removed. All
Yes.
the thought has been changed now. They say you can leave all endometriotic cysts behind and pregnancy will take care of them. And if it doesn't and the patient has problems after she delivers a child, you can see. But generally, we do not remove a cyst if you have made enough embryos and you can do the embryo transfer. This is what literature says. And I think, what do we follow, Bhavani? Do we remove cyst after we've made the embryos? Bhavani or Tejashri is here?
No, ma'am. We don't touch the endometriomas before FET.
Yes.
So,
So,
ma'am, I think it has to be individualized also at times.
yeah, that too
Uh,
is very important
so,
that if the endometrioma is very large and you had thought that you will
for
remove,
that,
say, a 8
yeah,
centimeter, uh,
yeah, if you were only waiting for getting good number of oocytes, so that by the surgery we are not harming the ovarian
mating
reserve.
reserve. Correct.
And after pickup, if we feel that it would be good to remove the endometrioma, it's a big endometrioma, and patient also has symptoms. If all that situation is there, probably we can go for surgery. But just for transfer, we will not remove it. Like
Yeah. So
just
if she has
only for
symptoms, you go for surgery. Plus, beware if you are removing a large endometrioma, you will probably leave very little ovarian reserve for her. Vara Lakshmi, Yathi Raju, you are upside down in the camera. What is happening? Are you with your phone, which is upside down?
Hmm. Ma'am,
Vara Lakshmi, Yathi Raju. Okay, come on.
ma'am, one more question, if you
Yes.
allow me. I couldn't
Yeah, please.
understand related to the adenomyosis. Why we need, I mean, what is the effect of the large uterus on the infertility issues? Why we need to reduce the volume of the uterus before treatment? I
Very
did it
important
maybe
question.
textbook point.
Very important question. See, when there are fibroids and there are type 4, 5, 6, 7 fibroids, we say don't touch them. There'll be no problem because the uterine length remains okay. It may increase a little bit with myohyperplasia, but not so much. This is known in a lot of studies now that if the uterine cavity length is more than 10 centimeters, implantation does not happen very successfully. And if a adenomyosis uterus is more than 100 cubic centimeters, then the cavity length also increases because adenomyosis as it happens in the muscle tissue, the whole uterus grows, including the endometrial cavity also, with that keeps on growing. So our
Oh,
main aim is 100 cubic centimeters is in one study. People may be reducing to even lower levels or maybe even higher. Sometimes we transfer in a uterus which is 150 cc also. You may not have estimated the uterine length, but if the length is more than 10 centimeters on sounding, such uteruses may sort of have a lower implantation rate, and hence we like to reduce the size. And adenomyosis is one thing where surgery is not a must. You can give GnRH agonist to stop the menstruation and ovulation, and since these hemorrhages will stop happening inside the muscle tissue, the adenomyoma reduces very beautifully.
mhm. Is it, ma'am, is it also affecting the natural conception? Because majority of the
Yes,
patient of the adenomyosis are asking, is this a condition affecting my future fertility? So this is a very new point to me.
it
My
should.
answer is always no.
No, it should not affect the future fertility or that fertility. You see one adenomyoma of 3 centimeters in the uterus, it will not affect the fertility unless her tubes are stuck and blocked and are non-functional despite being open. So no endometriosis affects fertility. No adenomyoma affects future fertility in case the tubes are functional and not stuck. But yes, as the lot of patients with endometriosis come with spontaneous pregnancy. So if the disease grows and there are a lot of adhesions and you have a obstructive pathology along with endometriosis, or the tubal pickup is hampered, or the ovary which is discharging a oocyte is not being able to discharge because a follicle has grown just under an adhesion or under the cyst. In those cases, definitely fertility will be affected. And similarly, with adenomyosis, also, if the uterus becomes very large and distorted, then fertility will surely be affected.
Thank you so much, ma'am. Very lovely to listen you again. Thank you.
Thank you for asking these questions because your questions make me think again and they make my knowledge more sort of um,
No,
robust.
it's
Yeah.
very lovely to listen you again. Thank you so much.
Okay. Any more questions, Bhavani?
Yes, ma'am, there are more questions. And Dr. Anupama wants to know about the role of microwave ablation in adenomyosis with
I have
infertility.
I have no idea about it, Dr. Anupama. You will have to read about it and you will have to ask someone who's using it. I've never used it.
Dr. Basima wants
Anyone,
to know which
anyone
method do you
amongst
prefer to reduce uterine size in adenomyosis?
No. I first want to ask Dr. Anupama, would you be able to ask the whole audience here if anyone has used microwave ablation in adenomyoma? Anyone has used out of all the delegates who have joined this talk? Please unmute yourself and answer in case you have. Anupama, where have you seen it?
Madam, they are using as gynec procedures. Those who are having dysmenorrhea, they are using microwave ablation and they are claiming that it reduces the pain. So,
Okay.
is there any role in fertility
I'm
cases,
not
madam?
sure. I've never heard it being used in infertility. Anyone has heard about use Tejashree?
Ma'am,
Dr.
ma'am, I'm Shalini here.
Huh.
I was about
Yeah,
to
ma'am,
use
this
it in a patient, but I know in BL Kapoor, Dr. Dinesh Kansal has used it. And there was another doctor, Dr. Priyanka Suhag. She used it in 3 or 4 patients. So I
Okay.
think
With
the long
Yeah,
term,
it
infertility?
is,
yeah, yeah,
ma'am, I
yeah,
think in a research setting and
yeah.
in the recent conference in AICOG, Dr. Asha Rao was here and she's considered one of the,
Pioneers for adenomyosis. Yeah.
consultants who deals a lot with adenomyosis and endometriosis. So there was someone from the audience who asked her, but even she said that I haven't used it yet. I
Okay.
No,
think
but
it's
this
under
much I know. Then
research
in BL
setting.
Kapoor, yeah, BL Kapoor, it has been done. I think 5 to 6 cases
So
has
will you
already
do
been done.
something, Anupama? Will you find out from BL Kapoor what they use, how it is used, and what results it has had in infertility, and put it on the forum for all of our knowledge? It would be so nice if you can do that.
Yes, madam. Can I
Okay.
have his contact number if anybody has, madam, please?
Yeah,
I don't know. Just
ma'am,
give us
I'll
name.
try to find it out because I have the number and I'm in touch with those people. So
Shalini.
I'll,
Huh.
Hanji ma'am.
Okay.
Yeah. So
So
I'll
you
find it
just
out.
find out, and whoever finds out, put it, we'll learn something
Yeah. Yeah,
for
yeah.
questions.
Yeah, ma'am. Yes.
Yeah.
Dr. Prachi has mentioned Endometriosis Foundation Conference will be happening in Hyderabad next week. They have a lecture and workshop on microwave ablation in adenomyosis.
Please ask your colleagues who are in Hyderabad, or if anyone is going and is a part of it. We would love to hear something about it in the next class. We can keep 20 minutes to hear about this only. It would be so nice to know.
Ma'am, Endometriosis Congress, Dr. Prachi here. Ma'am,
Yeah.
Endometriosis Congress will be held in March in
Hmm.
Hyderabad. So there they
Are
have
you
mentioned
attending
in the.
it? Are you attending?
I have not registered yet, but I was interested in the topic. So if I do
So,
attend, I will surely get back with
yeah,
the
then you give a
take back.
presentation of, 15 minutes to let us know how it is done, why it is done, and what results it
Sure,
have.
ma'am. Sure.
Okay.
Yeah. Thank you.
Okay, Prachi, we will look forward to your answer on this. And if
Yes, ma'am.
anyone
Thank you.
else, your friend is attending, you tell her to just get the slides on but
Yes,
I think
ma'am.
you have to attend it, not anyone else. Then you'll be able to explain.
Yes, ma'am.
Dr. Navita Suresh is asking if there is a large endometrioma and
Hmm.
IVF is planned, can we aspirate the endometrioma so that follicles can grow optimally and OPU can be done, easily avoiding cystectomy, which may decrease the ovarian reserve?
Navita, Suresh, I think, first thing is you have to see where are the follicles. Are they on the side of the vagina or are they on the side away from the cyst? So I wouldn't really advise aspiration of endometrioma so seriously, but people do it. It is not this that aspiration will lead to optimal growth of follicles, but you can see them better. That is true. But then refilling of the endometrioma happens very early. So when will you want to aspirate? On the starting of IVF, say on day 2 or 3, that time the patient is still menstruating. However, you can aspirate, but there is a high chance of infecting the endometrioma also. So beware that complication. Well, I would not advise aspirating it. Unless I would advise cystectomy if the follicles are distal to the endometrioma. And if they are proximal, I would just go quietly, take out as many eggs. And if the patient is young, pray to God that she makes good number of embryos so that and then after that, you can maybe do a cystectomy.
Dr. Sushila Kunte wants to know if there's any role of Mirena in adenomyosis for volume reduction before FET.
I think one of you should answer this. Lot of people use Mirena. Tell me. Large uteruses, Mirena may not work very well because if the uterus is really large, I don't think Mirena will work. But otherwise, it will work. Who of you? I use Mirena and adenomyosis for women who have completed their families mostly. But I'm sure that Mirena can be used in adenomyosis for some amount of volume reduction. It may not be very fast. What is everyone's opinion? Shalini, Tejashri, Bhavani, anyone else? Dr. Prachi?
Ma'am,
Sometimes,
actually,
ma'am, the size of the uterus is so big that I mean, Mirena will not even stay in big uteruses. It just
That is
slips
the
out
problem,
with
that
during
Mirena
menses.
doesn't stay, it expels out on its own in large volume uteruses. What is anyone's opinion on this? Anyone wants to say? I would be very
ma'am,
happy if all
when
participate.
ma'am, when EM junction zone is not.
Expels out when
uh,
the uterus is very large, and I haven't seen, even with the not that large uterus, I don't think so. I mean, I haven't seen so much reduction in the size, ma'am.
Yes, correct. Reduction is not there, but yes, symptoms of adenomyoma, if there is a lot of pain and there is a bleeding problem, that will really get sorted out with Marina. Right? Am I right or no? Anyone feels otherwise?
Yes, ma'am. The symptom control is very beautiful with Myrina
Yeah,
because
very
very
beautiful.
very
Correct.
fond of using it, but I never thought of the reduction in the volume. So now from onwards, I will look into this that whether there is a reduction also
Very
or not.
good.
So
Sushila is speaking,
this
right?
is a very important topic for my research as well because I'm working on the adenomyosis in the patient with a previous history of cesarean section. So I can go with the two
This Dr.
topics.
Sushila, is this Sushila speaking?
No, Anita Dilip.
Anita. Anita,
Yes.
please do it. And
Yeah.
I would be so glad if you can publish it and also put us interim reports here, that size
Sure.
reduction, how much size reduction happened
This
with
is a very
Marina,
beautiful topic you gave me.
and how much size reduction with GnRH agonist. Both would be very good if we can compare it.
Yeah, sure, sure. Thank you so much.
Okay, okay.
Ma'am, also when EM junction zone is poor or there are endometrial buds and glands which are
Yeah.
originating from the endometrium,
Hmm.
means the lesions which are nearer to the endometrium, in such cases, usually Mirena is said to be effective in some studies.
Okay, okay.
So according to the Musa classification, when we see the adenomyosis features,
Huh.
so whenever it is near to the EM junction zone or if there are endometrial buds and glands, such cases, for the local action of progesterone.
Okay. Marina is good.
Yeah, yes, ma'am.
This is very nice that you've told us this, because that Marina will only put in patients when they are um, wanting a FET, and you can treat these buds with high progesterone effect at the endometrial myometrial junction. But then this study which I showed advised hysteroscopy. And hysteroscopically, if you are able to see these
Cyst,
insertions,
yeah,
yes,
myometrial cyst,
and then
subendometrial
we
cyst.
haven't even cauterized them. This time in the conference, I saw one presenter, Dr. Renu Mishra, showing this, because she does a lot of hysteroscopies. And she said, all I do is just open up these areas, just in size, and some blood will come out, bluish blood, and you leave it as such. So we wanted to know whether she cauterizes that or not. But she said, no, don't use a cautery. I think cauterization could be a good thing, but then we can't do it on extensively on the endometrium. It will reduce the endometrial blood flow also.
Yes, ma'am.
Marina will help also, and but when you have a lot of endometrial buds at the endometrial myometrial junction, what do you want by Marina? How many months will you put in that these buds will disappear with the progesterone effect of Marina? This
Ma'am,
is a question I would
yeah,
have.
at least 3 months, like usually we keep along with the other add back therapies also. Like we combine it with GnRH agonist depot,
Okay.
and
Okay.
we see it after three
So
months. If
possibly
we,
wherever you've read it,
Mm,
please put it on the forum. Just write the reference and we can all read it. It would be great to be able to read. This is the main aim of this class, that you all are so well read that I would love to learn from everyone who's read something more than what we've learned in the class. Okay? So please put this also. This is
yes,
Anita
ma'am.
again.
No, ma'am, Dr. Prachi.
Dr. Prachi. So you are going to tell us about the ablation, Prachi. And number two, you will also put the link of the article where you've read that you can put a Marina along with GnRH agonist, and these cysts and polyps disappear faster in these patients. Okay?
Yes. Yeah.
Ma'am, I
All
have a
right.
doubt that would the Mirena later lead to endometrial thinning if when we prepare the patient for FET?
See, it should not lead to the thinning, I'll tell you, because even GnRH agonist leads to a little thinning, and it may take a little time. But Marina, maybe what you think is right, that it might need to a little difficult endometrial preparation later on. So Prachi, just find out all this and write whether it will allay this tension
Sure,
or
ma'am. Actually, like in our practice, I've not seen a thinning, but
okay.
yeah, I will try to find out and put, ma'am.
You try to find out and put, and so that we can read and we'll be so much more clearer that yes, with GnRH agonist, use Marina, the size disappears, the endometrial myometrial junction becomes clearer, and we can definitely go in for
Yes, ma'am.
transfer
And if you
faster.
remember me, last session, I told you I am a live example of the Mirena-induced endometrial atrophy.
Ah, wow. So, Bhavani, your doubt is very correct. Marina induced endometrial atrophy could happen.
Since the age of 35, I am in
What's
amenorrhea.
your
And
what's your name? What's your name?
Anita, I told you last
Geeta,
time
you
in
are
the
again. That's why you know so much about adenomyosis and Marina, because
yes.
we must read about it. Anita, please find out a reference that someone must have reported, and why doesn't your case be reported that you use Marina for how many months or years?
No, I used for the menorrhagia,
For
unexplained
how
menorrhagia
many? For how
contraception,
long?
5 years. 5
5
years.
years. And
Yes,
after
and I
5 years, your
I
endometrium doesn't
removed,
grow.
yeah, I removed at the age of 38, I think, and now I'm 49. After that, I didn't get the periods. My endometrium is very thin on
Uh-huh.
ultrasound, but whenever I am getting the proglutan, that is a simple HRT, my endometrium become ripe and very beautifully again, and I'm starting my cycles regular. So
Okay, so you don't have your periods on your own, but if you take a OC pill, then you have your periods.
yes,
So I
yes.
think, ma'am, it must not be because of Mirena. It is basically she must be having ovarian failure now.
Yeah,
That is
and
the
No,
why
reason.
my
even I
my
feel that.
my FSH is still at the age of 49. It's 10, 12.
No,
I'm not
FSH-LH
pregnant.
is not important. Please do a correlation with FSH and estradiol. But
Yeah, estradiol, even AMH is a good.
okay.
Yeah. So this is an unusual case, should be reported.
Should be reported. Why don't you all report these cases? Because we'll all, but then you must do all your hormones very well
Yes.
without any
Yes.
medicines for 1 month. Don't take
Hmm.
any medicine for at least 3 to 4 weeks. Do all your hormonal test and see what is really the problem. That you menstruate with OC pills, but you don't. Do you ovulate with medicines also?
I didn't check for. Yes, I progesterone. I checked very long back, but I'm not regularly checking the ovulation because we are
Hasn't
using the.
anyone put in a hysteroscope and see that you've developed adhesions inside, and that is why the endometrium doesn't grow? This could be another reason that intrauterine device for 5 years can develop adhesions inside, and hence endometrium will never grow.
But maybe, ma'am, the adherence sometimes we can see on the TVS scan. My inside, I mean, on the TVS, my uterus is very
When
neat
the
and.
when the lining is
Actually,
very
ma'am,
thin.
Mirena would not cause long-term atrophy. It will cause atrophy for a while till it is inside, but once it is out, I am an example of Mirena user, and
Mhm,
I had used it first time I got it inserted at the age of around 36, 37, and
mhm,
then it after exactly 6 years and few months, I think 4 or 5 months after that, again
mhm,
my menorrhagia recurred.
mhm.
So probably the effect of Mirena, which they say might last till 7 years, it lasted for 6.5 years or something, and
Okay.
then the effect must have washed off. And again, I started having menorrhagia, and
Mhm,
then after 2 3 months, then I got it removed, got it reinserted at the age of around 44 or
mhm.
45, and then sometime later in my life, I became amenorrheic completely. My menopause must have happened.
Is it
So,
Alopecia futila?
G, ma'am, yes, ma'am.
Okay. So, what I feel is that in your case, Dr. Anita, you could
Mhm.
have had some synechia inside, and when there are synechia, ultrasound shows a 2 mm endometrium, and synechia is very difficult to pick up with a very thin endometrium unless you put in a scope. So,
Okay.
no scope was put in, and you were saying you had very severe menorrhagia, and the Mirena really helped you. So these are
Yes.
cases where there must have been a little endometrial inflammation, growth, and a synechia is most likely over there. But then you say whenever you have OC pills, you have periods.
Periods like the menarche periods. Same, same pillow, same pain, same. Like I'm feeling myself young.
I
Okay.
just wanted to say that we should not take this impression that Mirena would cause long term atrophy. It will have its effect for some time, maybe 2 3 months, and after that, the effects
Unless
will
there has
be.
been some inflammatory changes inside and has led to synechia, because we do get patients who have had no periods for 2 3 years and ovarian function is fine, lining is very thin, and then eventually we find that there was all hysteroscope is put in and its whole cavity is obliterated. So, but these people then don't get periods with OC pills also. Bhavani, what is your
Ma'am,
opinion?
I feel that same concern would be there even when we are preparing somebody for FET, because if you're putting in a intrauterine device, risk of chronic endometritis will always be there, and we would not want that to happen. So, I mean, Mirena would not be our first choice if we are trying to reduce the size of the uterus. First thing, in adenomyosis cases, when GnRH agonists and letrozole works so beautifully.
Especially with these
Um,
people, especially
yeah,
with Anita giving a history, that her periods
Yeah.
stopped after that, and her FSH is okay, AMH is
Even
okay,
if the
it is
periods and
okay.
endometrial atrophy may not happen, but chronic endometritis ka element might occur with IUD in
She
the.
was not looking at fertility. The only thing is that her period
Hmm.
stopped, could be endometrial atrophy or adhesions, because her
Yeah.
ovarian function has been okay till now, as you say, FSH, LH, AMH, all is well. So it is endometrium. And adhesion is more likely to happen in cases where you had so much of menorrhagia, thick endometrium, and heavy bleeding. So in my mind, only this comes as a reason. ठीक
Ma'am,
है, so
doc
now I think we will say that we will talk about it was an thank you for learning. I just want to know, is there
Ma'am,
any studies to confirm that
one
endometriosis doesn't affect oocyte
last,
embryo quality apart from
yeah,
the study you showed on the slide? Please look into literature, you
ma'am,
will find.
one last question for the benefit of the audience I wanted to ask you is that when would you advise surgery in adenomyoma?
Yes,
Adenomyosis, rather.
adenomyosis.
Yeah. When would you advise to go ahead with the surgery for removal of adenomyoma?
Mavani, the question is to you. Bhavani's left the meeting. I think she's gone.
No, no, ma'am, I'm there.
So answer her question.
Ma'am, can you repeat the question?
Bhavani, I was just wanting ma'am to tell us that when would she advise a surgery for adenomyoma?
Ma'am, I think if she's not responding to medical treatment or if it's a very well circumscribed adenomyoma,
Yes, correct.
in
I
that
always like
case,
to remove adenomyomas which are 6, 7 centimeters, 5 centimeters, maybe, and very well localized adenomyomas. We've removed
Focal
large
adenomyoma.
adenomyomas because these uteruses will take a long time for reduction of this adenomyoma. And here surgery works fast. See, in surgery also you have to wait 3 months, and with GnRH agonist also you have to wait 3 to 6 months. So surgery over here is good. If the patient is young, it is a localized large adenomyoma. Anyone differs or want to give their opinion?
I think there is one more reason for which I have got it operated, two patients, that I just could not enter the upper part of the cavity. The adenomyoma was located this
Dropping
way.
into,
Yeah, so I just could not enter. So I had to got it
so it must have been a big one. And these are
removed.
generally posterior
Yeah.
adenomyomas where you cannot get in. You're quite right. When the cavity is half obliterated by the adenomyoma pushing into the cavity, it is generally large localized adenomyomas. Otherwise, just to reduce the volume, once upon a time in earlier days, I have done adenomyomectomies when GnRH agonist was not really so well known. And we used to do volume reduction. I've even put a drain into the uterine wall, into the musculature that we couldn't approximate very well, and there was little collection here and there. So those were very difficult surgeries. But now, at least, either we do a good localized adenomyoma removal or we go in for a GnRH agonist long-term treatment. These two
ma'am,
have.
Dr. Basima wants to know if you've tried Dynogist for volume reduction in adenomyosis.
Yeah, people do use Dynogest, but the fastest volume reduction is when you combine GnRH agonist with letrozole. That is the fastest. With Marina, the volume in reduction may be less, but then Dr. Prachi said that she will work for her students in this to see whether Marina causes size reduction or not. Am I right, Prachi? You had said that you'll do a study.
No, no, Dr. Anita.
Anita said, okay. So Anita is going to do a study on this, but even with Dynogest, reduction is definitely there, but I don't think it is so good. What is everybody's opinion? I've never done a study on this. None of my students have done a study on agonist versus Dynogest. Anyone has seen a paper or done a study?
The symptomatic relief is quite good with Dynogest, ma'am, especially in cases of endometriosis. But size reduction, I have seen
Don't
Dynogest working
think.
beautifully in young girls.
Mhm.
Even the size has reduced. It's like variable 50-50.
Okay.
but not in
So if you
adenomyosis,
are
ma'am.
to choose, if you've made embryos and you are to choose between Dynogest and GnRH agonist, what
I
would you
still
choose?
would use GnRH
You
analog,
would.
ma'am.
So we are more sure about
Yeah,
GnRH agonist,
yeah,
but I'm sure
yeah,
all drugs which control the growth of, which prevent ovulation and stop a lot of matlab heavy bleeding, would definitely reduce the size of the uterus or adenomyoma for that sake,
yeah.
and of endometriosis also, but
Mm,
not as much as GnRH agonist depot.
yeah.
Ma'am, I
Okay.
wanted to hear just a few lines on what was you had been doing adenomyomectomies in the past when GnRH agonist was not. So how did those patients go usually? Was it a very dangerous surgery
I
and the
still remember
results?
one patient who used to give me a nightmare, whom I had done a adenomyomectomy. Shweta was my assistant in those early 2000 days. And it was a large adenomyoma. निकालते जा रहे थे और लग रहा था अब clear आ रहा है. And I went into the left side of the uterus, and there was hardly any tissue
Myometrium
left on the
left.
left side to really suture. I don't know how many sutures I put, and we did an embryo transfer. She had failed multiple places and she conceived. And
Oh.
after 7 months, every day I used to think, Abhi, I'll get a phone from Deepika that she's ruptured her uterus. But then we did a cesarean at, I think, 36, 37 weeks, and she has a very beautiful child. And she's become a very good friend-like person, after all this. When I used to tell her that, I was so scared about you. You did get pregnant, but every day used to be a nightmare. That tomorrow I'll get in the night a call that she's ruptured her uterus. So this risk was always there with, surgery.
When you did her cesarean, did you find her uterus to be abnormally hard or something?
Yeah, adenomyosis was still there. A lot of people have done adenomyomectomies, and I've had placenta previas with them. I've had to do hysterectomies at the time of cesarean also, but that was mostly in the early 2000s. After that, we've got GnRH agonist, which is such a wonder drug. You won't understand what a relief it is not to take these patients for surgery.
Hmm. Oh, thank you, ma'am.
Okay. Thank you, everybody, and please get back to me with all the answers. Thank you. Good night.
Thank you. Thank you,
Thank you,
ma'am.
ma'am.
Thank
Thank you
you
so
for
much,
all the
ma'am, and
Bye.
thank
insightful.
always a
You all
pleasure
for
to
making it
listen to
such an
you, ma'am.
interactive session.
Bye.
Thank
Yeah.
you.
I
Bye-bye.
really wanted to be interactive. तुम लोग भी पढ़ के आया करो. When you want to put in questions, bring in a reference and put the reference there. So it will be very challenging for all of us to read more while we present. Thank you. Bye.